All right. Yeah, so previously we kind of went over all these parameters and how to measure them and what they mean. So now we'll go more into uh, how we're going to use these parameters to kind of diagnose diastolic dysfunction and to distinguish between different grades of dysfunction. So pretty much for the most part, again, as we talked last time, you need these four things. These four things to kind of diagnose diastolic dysfunction. So the septal E prime velocity, lateral E prime velocity, average mitral E velocity to E prime velocity, TR velocity, and the LA volume index. So we're not going to go over the left atrium index because I think it's a totally different topic. And pretty much for the most part, you can get away without this index. So if you have three things normal, that's a normal diastolic filling pressure. If you have three or more abnormal, that's increased filling pressure, that's diastolic dysfunction. And if you two and two, then you need to look at more parameters to figure out what's going on. So the septal E velocity, so we look at the medial velocity, at the lateral velocity. Medial is usually slower than the lateral velocity. We looked at the average E to E prime velocities, so they should be less than 14. And so for the normal, so just quickly go over the normal velocities. E to A should be more than 0.8. E prime medial should be more than 7. Lateral should be more than 10. Uh, so yeah, this number. So E to E prime medial should be less than 15. Lateral should be less than 13. TR velocity should be less than 2.8. Left HM volume index should be less than 34. IVRT should be 70 to 90 with E to A ratio 1 to 2. Yeah, just to remind about the IVRT, that's the time uh, between the aortic valve closure and mitral valve opening. And mitral A duration should be more than PVA duration. In the pulmonary vein systolic wave should be more than diastolic wave, and there should be no anatomic abnormalities. Yeah, so this is systolic. So S1, as we discussed previously, should be there, but in up to 70% of people, it may be not here, but the S2 should be more than D. And the pulmonary vein A duration should be less than mitral A duration. So knowing all of this, if anybody is brave enough to guess if this is a normal or abnormal diastolic pattern. All right. Anybody want to try?
Normal, I guess.
Yes. See, that's a good test taking abilities. Yeah, so this is E, this is A. So E is about 10, A is about like 0.5 or so. This is the medial E prime, this is lateral E prime. So lateral is a little bit faster than the medial, but whatever, the both of them are normal, right? So the medial one is more than 7, the lateral is like about 21, so it's more than 10. TR velocity is less than 2.8, and E to E prime ratio is less than 14. So this is normal. Then we go into abnormal patterns. So by guidelines and by all, so this is how you should approach it. So basically you have three, uh, so after you have just EA, just the mitral inflow velocities, you will have three possible outcomes. So one is if EA less than 0.8 and E is less than 50. So this is grade one diastolic dysfunction. And if you have E to A more than 2, this is most likely grade 3 diastolic dysfunction. There's a little caveat which I'll go into later, but for the most part, if your E to A is more than 2, then it's grade 3 diastolic dysfunction. So then everything else is kind of in between. So if your E to A is less than 0.8 and E is more than 50, or your E to between 0.8 and 2, then you should go and evaluate more parameters. So at least these three, right? So uh, average E to A, TR velocity, and left atrium volume index. So if 2 out of 3 are negative, normal, then it's going to be grade 1 diastolic dysfunction. If 2 out of 3 or 3 out of 3 are abnormal, there's going to be a the grade 2 diastolic dysfunction and increased left atrium pressures. If you only have two criteria, so for example, again, you don't have the left atrium volume index, so two normals are going to mean that you're grade 1 diastolic dysfunction. Two abnormals are going to mean that it's grade 2 diastolic dysfunction. And if one is normal, one is abnormal, you cannot really determine the dysfunction grade. So you need to look at more things. Uh, so yeah, so first of all, yeah, so we look at this, right? So A is 80 centimeters per second. E is 50, like around 50. And then E to A ratio is less than 0.8, and E medial. So this one is for the medial one. So E medial is like 7, less than 7, and the lateral E prime is less than 10 centimeters per second. The deceleration time, as you see, is white, and E to E prime ratio is less than 8. So all of this is basically grade 1 diastolic dysfunction. And so this is the first time when we see that the A is bigger than E. Also, yeah, if you look at more parameters, so in this case, you don't really need to look at more parameters, because if you go by the diagram, right? So the E to A is less than 0.8, and and the mitral inflow E velocity is less than 50. So that's already enough to diagnose the grade 1 diastolic dysfunction. But if you would look for more parameters, you'll see that the TR velocity should be less than 2.8. Left atrial volume index should be less than 34, but not maybe not always. The IVRT more than 90. Mitral A duration would be so depending on the LVDP would be either longer than pulmonary vein pulmonary vein HO wave, or shorter. So if the LVDP is higher, then the PVA would be longer than the mitral A, and PVS2 would still be more than PVD. So these patients, like a little clinical caveat. So there was a study that looked at the EA ratio. So it seems for the ischemic cardiomyopathy. So it seems like 0.6 to 0.8 is the best range of the E to A ratios in terms of mortality for this patient. So if you can keep them in this ratio, then they will live longer. Um, so usually these patients will not have significant symptoms if the diastolic filling is sufficient. So this is why you should try to prevent exercise-induced tachycardia and atrial fibrillation. So this patient will do better with the beta blockers. All right. Yeah. Somebody want to say something? No? Okay. So what about this one? Anybody want to try?
Grade 1?
Huh?
Grade 1, no?
So it's so this is actually one of the things where all so at least I don't know, at least when I was reading the part about diastology, first of all, there's like a ton of little typos, which then you need to figure out, is that a typo or it's not a typo. And another thing is that so there are two classifications. One is the Mayo classification, and the one is the guideline classification. So the thing about this one, again, so the E to A ratio is about 0.8. Your medially prime is 5, laterally prime is 7, and E to E prime ratio is so medial 12, the lateral is 8, and TR velocity is higher than 2.8. So this is by Mayo classification, this is grade 1A. By guideline classification, this is grade 2. So basically, the thing with it's like grade 1, kind of grade 1 pattern, but with the higher feeling pressures. So for grade 1, you shouldn't have this high feeling pressures. So I don't know, this kind of
So the
question.
only giveaway is like the TR velocity is more than the
Is
TR.
yeah. So the feeling pressures are higher, yeah. So I mean, maybe this is a question to Avi if he's still here. I don't know, for the boards, I guess we should go with the guidelines, but I'm not sure.
Avi?
Go with the guideline.
Go with the guideline. All right. So what about this one? Any ideas? So yeah, just in case here. So this is the mitral inflow. This is the mitral annulus velocities, and this is the TR velocities. So grade 1, 2, 3.
Should be 2 because the EA is not more than 2. Eh?
Okay, somebody's been cheating and reading ahead. Yeah, so E here is going to be like 125 or so. A is 110. So then your E to A is 1.5, 1.1. Your DT is not bad. So this is going to be pseudo-normal, which another way of calling it is, I guess, grade 2. So yeah, if you go by this little thing from the guidelines, um, so your E to A ratio here is between the 0.8 to 2. So we need to look at more stuff to figure out what is this. So yeah, so number one, so TR velocity is higher, so like almost 3 here. Then you look at the E prime at the mitral annulus velocity. So E prime medial is 3 centimeters per second, so less than 7. E prime lateral is 6. So that makes your E to E prime ratios are 20 or 40, depending on medial or lateral, which is more than 13 or 15 that we need. And if you look at the pulmonary vein flow velocity, so D is bigger than S. And yeah, so this is kind of the thing that we discussed previously. So if you do Valsalva, so you will kind of you can distinguish between normal and pseudo-normal. So if you do Valsalva maneuver while doing echo and measuring the mitral inflow velocity, so in pseudo-normal you will see this pattern. So the E to A ratio was 1.1 will become 0.5. In normal, you will not see this. You will see that both the E and A will decrease, and the ratio will not change dramatically. So this is grade 2. For the kind of clinical things, so these patients have moderate increase in feeling pressures and impaired relaxation. So they will do better if you decrease the preload and congestion, and if you give them ACE or ARP for the neurohormonal modulation. So another thing is, yeah, anybody knows what is this little thing? So this is E, this is probably A, but what is this little thing here? All right, so I'm gonna tell you. So this is the L wave. So you can have it in mid diastole. If there's a drop in the LV pressure in mid diastole, then you can have this. And basically in two scenarios. So one is the prolonged relaxation, high left atrium pressures, and another one is can be seen in young and healthy people. But usually in young and healthy, it will be less than 30 centimeters per second. So if it's more than 30 centimeters per second, then it's like a sign of high pressures. And you can also see it, so this is the mitral inflow velocities, but you can also see it in the mitral annulus velocities, and in the pulmonary vein flow velocities. You can also see this L wave. So another thing is this. So pulmonary PVA in these cases will be longer than the atrial wave of the mitral inflow. So you can see here mitral A wave ends around on the top of like R wave, but the PVA ends later. So it should be, but not always, more than 35 centimeters per second, and it should be longer than if it's longer than the mitral A, then this is another sign of high filling pressures. And the third thing that you should kind of keep an eye on, that we kind of discussed last time, but we'll go over it here also. So in a normal situation, so the in the diastole, it's like the low LV pressure is sucking blood from the left atrium, and that's causing the kind of the blood flow and the filling of the LV. In the abnormal, if there's diastolic dysfunction, then it's more the left atrial pressure is pushing the blood towards the LV, and not the LV sucking the blood from the left atrium. So because of this, the pattern of so the pattern of the not the pattern, the timing of the mitral inflow velocities and the mitral annulus velocities are changing. So if the LV is sucking the blood from the left atrium, then mitral inflow, the E wave of the mitral inflow and the E prime of the mitral annulus, they start pretty much at the same time. If you have higher filling pressures, then the E prime velocity starts a little bit later than the E velocity. So if you have E before E prime, that's another sign of high left atrial pressures. But just to finish this one, so yeah, based on what is written in O, kind of seems that they don't really recommend going and measuring this too often. So unless you're like totally confused and this is the only thing that can help you, you should probably check it. But from what I understood from O, that usually it's very tedious and you can kind of get most of the information without it. All right, and what do you think about this one?
I mean, you left us with grade 3, basically.
Yes.
Yeah.
All right. See, Mazin can take any test without knowing. I mean, he probably knows a lot, but even if he doesn't know anything, that's very easy to figure out. So yeah, so basically this high E is a sign of high left atrial pressure. Then the A wave is kind of smaller because the left ventricular pressure will become higher very fast, and it will kind of counteract the atrial pressures. Then your E to A will be more than 2. So again, if you remember that little thing in the beginning, if your E to A ratio is more than 2, that's already enough to diagnose the grade 3 diastolic dysfunction. But yeah, so one little caveat, you can have you can have E to A ratio more than 2 in actually young and healthy patients. But then if you go and check all the other parameters, they should be normal. Yes, another thing, if you look at the pulmonary vein flow, so you'll have the D much higher than S. If you look at the medial waves, at the mitral annulus velocities, so the medial one will be less than 7, the lateral will again be less than 10, and your E to E prime ratio will be more than 13 or 15, depending on which one you use to measure it. Another thing is, so your left HM index will be high, will be more than 34, but apparently not always. IVRT will be less than 70. Mitral A duration will be shorter than the PVA, which we already discussed. PVA velocity will be more than 35, but not always. And this one will not be reversible with Valsalva. So this is grade 3. And another one, yes. So again, for Mayo classification, there's a fourth fourth grade of the diastolic dysfunction. But for the guidelines and for the boards, pretty much this is the worst. Grade 3 is the worst. And so these patients, yes, so they have markedly high feeling pressures. So they get most of the feeling of the diastolic feeling in the early diastole. They have fixed stroke volume. So these patients may not actually tolerate beta. They may not tolerate beta blockers too good, because you cannot really they cannot really augment their stroke volume in bradycardia. So they should be on the diuretics, obviously, to decrease the pressures, and on ACEs and ARB. So beta blockers may be a questionable for these patients. So yeah, just quickly, conditions that will cause this kind of grade 3 diastolic dysfunction: decompensated heart failure, advanced restrictive cardiomyopathy, severe coronary disease, acute severe aortic regurgitation, constrictive pericarditis. And this is just a quick summary of these patterns of the diastolic dysfunction. So in the normal one, this is what we see. So we'll see that the E is more than A, and whatever all the parameters that we already discussed with the TR velocity is less than 2.8, left HM index less than 34. As you go on, so grade 1 diastolic dysfunction, the A becomes bigger than E. Left atrial volume index can be different, can be more than 34, can be less than 34. And mitral annulus velocities also change, so A becomes more than E. Then for grade 2, that's the pseudonormal pattern of the mitral inflow, but you can easily distinguish it from normal by looking at the mitral annulus, and this is why the guidelines don't really recommend using Valsalva maneuver to distinguish pseudonormal from normal, because there's a lot of human error involved in using the Valsalva maneuver. But with the mitral annulus, you can easily distinguish normal pattern from abnormal. And finally, grade 3, E velocity is very high, A velocity is very low compared to normal. And all the other feeling pressure, the TR velocity is high, and the left atrium volume index is also elevated. So yeah, to me, kind of when I'm looking at it, it kind of resembles the seesaw kind of thing going on here. So I don't know if it helps anybody, but I spend like an extra 10 minutes doing this instead of doing something more useful.
Very helpful. During the exam, I would just be thinking of seesaws.
I think it's too much helpful. All right, so yeah, so then obviously a lot of these patients will have AFib, right? So for AFib, a lot of things will be, not a lot of things, but few things will be, will not fit like the usual criteria that we use. So number one, there's no A wave, because in A wave basically comes from the HO kick, and in AFib, HO kick is gone. Another thing is that the E waves are not as regular as you want them to be, and they also depend on the cycle length and where they end. So what is recommended is, so the deceleration time has a good predictive value. So you measure deceleration time in those E velocities that end before the onset of the QRS. So this one, all of them end before QRSs. So you can measure all of them and then draw some conclusions. This one, not all of them end before the QRS. So 1, 2, 4, and 7 end before QRS, so we can measure them. But 3, 5, and 6, they end. So they end like on the QRS. So QRS starts while the E velocity is still going. So we don't use these measurements to. We don't use these E velocities to measure the deceleration times. But if your deceleration time is less than 160 in these E velocities that end before QRS, that's a sign of increased filling pressures. Or if your deceleration time is less than 220 in the pulmonary vein flow, then this is also a sign of increased pulmonary pressures. So another thing is that you can also have this L wave if the filling pressures are high. On the E prime, E prime velocities can be in the mitral annulus can be different from cycle to cycle. So you use 3 to 5 cycles to find the average and use that for your calculations. And in terms of E to E ratio, so seems like if E to E prime ratio more than 11, the studies show that basically if it's more than 11, then filling pressures are more than 15. So you can use this number to kind of estimate your filling pressures. So another thing which will kind of complicate your measurements is this. So your S is yeah. So number one, you see that the E velocity is about 100. Your mitral annulus velocities are low, 3 and 4. Your systolic wave is bigger than diastolic in pulmonary vein, and your TR velocity is less than 2.8. So this is what you can encounter with the mitral annulus calcification. So obviously, if the mitral annulus is going to be calcified, that's going to affect your mitral annulus velocities, and it will also affect your E velocity. So so the E prime velocities are in the moderate to severe mitral annulus calcification. The E prime usually is about 20% lower than it would be if there would be no calcification. And E to E prime is 40% higher in moderate to severe calcification compared to patients with no calcification. But this doesn't mean that the filling pressures are necessarily high. So if you see mitral annulus calcification on echo, so then you have to adjust for this, measure all the other parameters to kind of also see your filling pressures. And there was a study that showed that that proposed like this this kind of algorithm to figure out what's going on with the filling pressures in mitral annulus calcification. So if your E to A is less than 0.8, that's going to be normal. If your E to A ratio is more than 0.8, that's going to be high. If it's somewhere between 0.8 and I think, yeah, so it looks like there should be 1.8 actually. If this one is, if mitral E to A ratio is 0.8 to 1.8, then you look at the IVRT. If it's short, then the filling pressures are elevated. If it's not short, then the filling pressures are probably normal. So a few words about if you have any problems with the valves. So if you have mitral regurgitation, so your E velocity increases with the rate of free regurgitation. This makes E to E prime not 100% reliable. The systolic component of the pulmonary vein flow will be reduced. Deceleration time seems to be correlating nicely with LV filling pressure, so you can still use the deceleration time. And so, yeah, I said that E to E prime is not 100% reliable, but if it's more than 15, that's kind of good enough. So that correlates with high pressures and outcomes. And you can also check the IVRT and the IVRT to the index of E to E prime. That's the time difference between the E and the E prime velocities, which we talked about previously. And this is all the same parameters goes for mitral stenosis, but usually the diastolic pressure should be, unless there's some other problem, should be okay with mitral stenosis. In aortic stenosis, most of them will have diastolic dysfunction. Most of them are older. Most of them have coronary disease and LVH and so on. So E prime will usually be reduced because of, again, LVH, increased overload, abnormal relaxation. So the severe the aortic stenosis will also give you the more severe diastolic dysfunction. The interesting thing for in terms of clinical aspects is that aortic stenosis, if these patients have dyspnea, this means that they have at least grade 2 diastolic dysfunction. But if they present without dyspnea, but they have chest pain or syncope, they probably have so the grade of diastolic dysfunction is less. So again, the presence of dyspnea in patients with aortic stenosis is kind of poor prognostic factor. E to E prime ratio is prognostic in these patients, and the interesting thing again for TAVR is if so patients can continue to have dyspnea even after the even after the even after the replacement of the aortic valve, if diastolic function is severe. So checking diastolic function and dysfunction in these patients is crucial when you decide about what to do with this patient. So if you cannot control diastolic dysfunction, then clinically for them, TAVR or SAVR will bring less benefit than for other patients. In aortic regurgitation, so it can be chronic or acute. So in chronic, LV is dilated and compliant, so they have less diastolic pressures and they less increase in diastolic pressures, and they don't decrease for a very long time. Different situation in acute aortic regurgitation. So LV is obviously not ready and it's not dilated. So pressures rise, pressure rises very fast and so fast that it may even force mitral valves to close prematurely. So these patients usually have grade 2 or 3 patterns right away, and so you also should look for this in patient for the diastolic dysfunction in patients with acute aortic regurgitation. And this is it. See, you get this joke?
We got it loud and clear.
That's the best I can do.